welcoming by welcoming Dr. Mark Levine as our seminar speaker. This is not a formality. We asked Mark to present a seminar really because of his enormous contributions to graduate medical education, but most important and most relevant to what we are encountering now is Mark's role as the architect really for where we sit in current public health and his contributions during the pandemic to overcoming vaccination hesitancy, COVID testing, contact tracing, policies and practices that really were a paradigm for being able to get through that difficult period locally, regionally, nationally, and beyond. So, Mark, we owe you a great debt of appreciation, and we very much look forward to your presentation today and that to share with us your perspective on where we sit in terms of being able to address health and from the standpoint of public health. Connie, the floor is yours.
Thanks. Thanks, Gary, and welcome everyone. My name's Connie Van Egan. I'm an associate professor in the Division of Public Health in the Department of Medicine in the Larner College of Medicine. And it's my honor to introduce Dr. Mark Levine and to say just a few brief things. So thinking that most everybody is familiar with his name and with him himself. Dr. Levine was appointed Commissioner of Health by Governor Phil Scott on March 6, 2017, and served for 8 years until last April. Prior to becoming commissioner, he actively practiced general internal medicine with special interests in solving complex diagnostic dilemmas, health promotion and disease prevention, screening, and clinical nutrition. Dr. Levine has gained a reputation as an outstanding teacher and educational program innovator, receiving teaching awards from the medical school and the Department of Medicine. He maintains his faculty appointment as Professor of Medicine at the University of Vermont Larner College of Medicine and continues to actively teach. Dr. Levine, welcome.
Thank you both for those kind comments. I hope to leave you with this talk not in a totally hopeless frame of mind, but I do want to not poo-poo the gravity of some of the situations that we're dealing with. So what we're going to do today is briefly go over some Public Health 101, if you will, just to set the stage very briefly, and then move on to what I and many others consider our greatest public health threat in the 21st century, which is climate change and its key health impacts, and then conclude with really what should keep my successor, who just began a few days ago, up at night in this time of political turmoil. And I don't use this term lightly, but truly dismantling of public health in the United States. So we'll start with just a view of the department that I no longer lead, just to give you a sense of the loftiness of the vision and mission statements and values, and the fact that the department is not got its head in the sand and refusing to use words like equity, like inclusion, and certainly like data, being science and evidence-based. Moving along, the WHO's definition of what is health is a state of complete physical, social, and mental well-being, not merely the absence of disease and infirmity. And I stress that only because most people think of health care when they think of health. That's the first place they go. But this is health. And in public health, it's really what do we as a society collectively do to ensure the conditions in which we can be healthy? And, most of the time, public health, through its long, centuries-long history, focused on three things: preventing epidemics, as we've just seen recently, or at least dealing with them, environmental health, because there are so many hazards in the environment, and then preventing chronic disease through health promotion, disease prevention strategies. In modern times, we continue to do all of that, but superimposed is the acknowledged need to have intersectoral partnerships and collaborations. Public health does not do all the things in that definition of public health by itself, as if it were one agency, they do all their work and we're all fine. It really is a society-wide aspect. And this complex slide I'm going to show next is really the way of framing that, if you will. You'll notice the arrow at the bottom with downstream and upstream, with upstream being the most advanced, if you will. But on the right, we have in the downstream area, healthcare, treating disease and injury, and educating and dealing with high-risk behaviors. Now, we all know that if you look at the determinants of health, only about 10% of health is determined by healthcare. Another 30+% has to do with the behaviors that are in that list that lead to disease states. And then the rest of it is really all socio-political, economic, and environmental aspects, which the left-hand part of the slide really illustrates. So the living conditions used to be called the social determinants of health. Now it's more commonly referred to as health-related social needs, but really access to wealth, not being in poverty, having housing, transportation, and food security, having access to healthcare and education, etc. And then the most upstream is the most left of the slide, which is dealing with inequities. Because even in Vermont, we know that we're always one of the half dozen or so healthiest states in the country. But if we look at the average Vermonter, we would think everybody's quite healthy. But the reality is the health disparities are really accentuated in the groups that have had discrimination, bias, prejudice, whether it's through class, whether it's through sexual orientation or disability status, etc. And then my final slide in this introduction part has to do with what has the most impact from a public health practitioner's point of view on the population's health. And this is called the health impact pyramid. The top three parts of the pyramid really are what I did as a clinician over a very long career in internal medicine. A lot of time working on counseling and education, treating the chronic diseases that are so prevalent in our society, and doing what we call health maintenance or prevention, trying to do things like make sure people's immunizations were up to date, that they had their colonoscopy and cancer screening and cardiovascular screening, etc. The bottom two rungs are really where public health shines, changing the context, making the individual's default decisions healthy. If you live in a community that has fluoride in the water, you're taken care of in terms of your teeth. If you live in this country now, we almost never use trans fat in crackers, so you can buy crackers assured that you're not getting the most toxic kind of hydrogenated fat. If you go to a restaurant, you're not going to get, through secondhand smoke, lung cancer, because we've protected you from that. And you don't even have to make decisions about these things. They just happen as part of policy. Now, there's always this tension between creating a nanny state and creating a very savvy state, and one has to deal with that. And we'll get into that a little later. And then the bottom rung is just dealing with all of the socioeconomic factors, which are the largest determinants of health. But when you deal with them, and the catchy lingo is housing is healthcare, you do more for healthcare of an individual than you could have through numerous other medical interventions. So that's our introduction. And now we're going to move on to really talking about climate change, as I promised. And the next slide will illustrate exactly the messages I want to give. One thing I'm concerned about with climate change is people get so caught up in carbon offsets and greenhouse gas emissions and how many rebates for electric cars, and they lose track of the fact that there's only one reason we care about climate change, and it's because we have to be able to continue to live on the planet, and our planet's health determines our health. And now, as a public health structure, but also throughout all sectors in state government, we really need to integrate climate change adaptation into public health practice. And that's really going to be our motivating forces. So, in the next slide, you'll see that I'm not saying this as some lunatic out there on my own. The WHO, all the major healthcare organizations here and across the world, all of the journal editors of all the major journals have all agreed that this is our single biggest health threat facing the human race. And it's unfortunate that we now live in a country where we've abandoned the Paris Accords. We now are drill, baby, drill, and we're not financing solar and wind, and in fact, clawing back some of the progress that we were hoping to make. I don't have to convince anybody here about the impact of climate change itself. We've now had 3 consecutive years where we've dealt with floods in July. This year was the least of the 3, but still had a major impact in parts of Vermont. We still had days this year where people were told, not only if they had respiratory illness, but anyone, that they might want to consider what they're doing outdoors and consider how much time they're going to be indoors because of the air quality from all of the fires in Canada that continue to rage year after year after year. We've been through Maui and Los Angeles, which have, I think, rather conclusively been attributed to climate change as a significant part of why they happened. July has been the hottest on record now, years on end. We are going to talk about mosquitoes in a second. Knock on wood, hurricanes have not been as impactful this year, but we're still not at November, and there are more brewing. And then you've probably read lots about the polar bears and a glacier retreat and what's predicted about Arctic ice, which is an ongoing saga. So just to look at, this is Vermont, this is Barrie, not this summer, but the summer before. So this is real, and it's certainly real in our brave little state. But now to look at the key impacts of climate change that we as a health department and society really need to focus on. Heat, storms and floods, vector-borne disease, cyanobacteria blooms, which I'm not going to say a lot more about, so I'll just say it here, nutrient inputs from increased precipitation. It turns out this year we had abundant lake and beach closures from cyanobacteria, but I would dare say we had more from E. coli than cyanobacteria this year, which leads to water and foodborne disease, and then the air quality impacts I just talked about. So we're going to talk about a few of these in more detail, starting with the next slide. Thinking about heat, we are, as Vermonters, a very susceptible population. The bottom line is we have 3 times the national rate of lacking air conditioning in our homes. Many of you may actually attest to that. We now have guaranteed, it seems, 15 to 20 days of greater than 90 degrees. That's 3 times what anybody ever had who moved to Vermont 10, 20, 30 years ago. Our heat risk is accelerated by the aging demographic that we have and some of their underlying chronic conditions and the medications used for those conditions. And people in the rural state, which NNE knows all about, have extra risk factors in terms of social isolation and having rural hospital access issues. This year, the heat advisory threshold was dropped by the National Weather Service to 95 degrees from 100. And we're susceptible in Vermont, even though we don't necessarily have months-long engagements of 90 degrees or higher, because it's populations like ours that aren't acclimated that suffer with very short durations. Looking at wildfires, we have more days per year with exposure, and that's on the increase. And it's harmful gases like carbon monoxide, volatile organic compounds, but it's also the particle size. And you may have heard about PM25 size. That's just a size of a particle that can get into your distal alveoli and wreak havoc in that arena. But it's not just a cardiopulmonary impact. It turns out these wildfires can have major impacts through some of their effects on neurologic, infectious, depression, PTSD, and low birth weight from pregnancy. And now we're at the point where places like people living in Los Angeles know about grab and go bags, things that are readily available so that when they are given the signal to get out of town, they don't have to spend another half hour looking around for what they might need in terms of medications and supplies. It's already packed. The public health implications, obviously, are staying indoors, HEPA filters, using N95 masks as the most effective when they are at high-risk situations, and increasing bronchodilator use for those who already have ongoing respiratory disease. Not a lot else people can do. When it comes to heat, there is a lot we can do. There's obviously an increased intensity of heat waves in the US. You can have very mild symptoms like heat cramps and very severe symptoms like heat exhaustion and heat stroke. And again, it doesn't require an extended period of time. There are numerous correlations between emergency department visits and hospitalizations. There are impacts, again, beyond the cardiovascular symptom. Think about kidneys in a relatively volume depleted state. Think again about mental health and birth outcomes, all associated with adverse outcomes from heat situations. Fortunately, most communities in Vermont now, through the public health structure, have heat action plans. We have grid alert systems. People are now accustomed to checking on the elderly. We have cooling centers throughout the state, and we have a map that people can go on at a time of need to see where the one closest to them is. We have less need than some of the urban areas for this green infrastructure that the slide refers to, but it's still obviously sage advice, as are reflective services in the typical urban setting. But rural Vermont is clearly not protected just because they're rural. Thinking about floods, which is our most common problem, it seems, numerous levels of how one can get injured or worse from floods, mechanical, lack of ability to use recreation, chemical exposures, waterborne diseases, which we've had a number of. Fortunately, Vermont has only had a fraction of the deaths that places like Texas recently had this year. And there was a whole article in the New Yorker that John Seabrook wrote about this. And it turns out perhaps some of the ways we think we're mitigating future disasters by redirecting rivers is fallacious. And some of you may be aware of some of the geologic work being done to really reimagine how we have to live in flood zones and try to avoid doing that, of course, but not thinking we can excavate our way out of it necessarily. Disruptions in the healthcare system are critical, and they may be as simple as you can't get to your pharmacy. and the nearest pharmacy may be 40 miles away if you're in the Northeast Kingdom, or they may be as severe as you're on an island now and you can't leave where you live and get to your doctor even if they were open. Like other climate change risks, there's an increased risk in pregnancy. I'm going to say more about mental health impacts in a few slides. And then we have a little bit of what's called redlining, even in Vermont. You know, redlining is traditionally thinking of places that are urban, where those who are poor or defined by race or other criteria end up living because they couldn't purchase homes in any other part of the city due to discrimination. And they have higher rates of disease related to sort of the jungle aspect of where they live in terms of the what's called the pavement jungle or what have you, where there's no greenery. There's more emissions from factories in that part of town. They have the worst water in that area, which may put them at risk for other diseases, etc. Well, the spine of the Green Mountains has a lot of people living in mobile homes, and they're defined more by ruralness and poverty, but are living in these higher risk places. So we do have some of that in Vermont. Moving to the next slide, there are ways to intervene, and they go a little bit beyond the scope of the talk right now. But clearly, we are doing a fair amount in the preventive and preparedness aspects of what the slide talks about. We do really well in the response phase. So the sequelae to floods, if people have survived the flood and are comfortable at that point, they have to understand that within 24 hours of being moist, their drywall is to be trashed. It only takes 24 hours to cause mold. Also, 40 to 50% of Vermonters do not use public water supply. They use their own wells or springs. And there's a mandatory need to test those after a flood situation for bacteria and for volatile organic compounds and other chemicals. Fortunately, most of the testing we've done in Vermont has only shown bacteria when it's positive. And then, of course, there are long-term needs in recovery, which we see how long a process that takes. Next slide. Going to zoonoses, or infections we usually see in animals and now are seeing more in humans, climate change plays a very significant role in terms of the length of seasons, especially where the vectors can live longer and breed longer and be alive longer and infect people, as well as the frequency of adverse effects. And the mobility of the population, of course, plays a big role in this. Our encroachment on the ecozones where animal environments began, and now we're sort of encroaching on those and destroying some of the habitat. Numerous examples, whether it be COVID, if you're subscribed to that, or avian flu, tularemia, hantavirus. We now have mosquitoes that never left the US. They were part of the US mosquito supply who have transmitted malaria to people who never traveled in states like Florida, Texas, and Maryland, that is well documented now, leads to great concern. There's also mounting evidence that leprosy is endemic in Florida. We have West Nile virus, which we don't even talk about anymore, but it's now endemic everywhere except, I think, one state. And Triple E, which we'll talk about in a second, Vermont. Tick-borne illnesses often get neglected now that we have mosquito-borne illnesses to worry about all the time. But everyone knows that the ticks are surviving throughout the year in Vermont. Winter is not as severe as it once was, and they can survive under snowpack and don't have some of the severe temperature decrements that would kill them off. And while we still see Lyme at a robust rate, it's the other infections that are increasingly more common. babesiosis, anaplasmosis, and Powassan virus, with the latter being something we have no treatment for at all. And unfortunately, our only preventive tool in the toolkit is to say, don't get bitten by a tick, and try to help people understand what they need to do that. Just rounding things out with climate change, mental health is really a neglected area, but when you look in the literature, there's substantial effects on mental health. 25 to 50% of people who have been through an extreme event like flood or heat wave having significant mental health issues that can become quite severe. And these don't just go away overnight, they can persist. In fact, there's a new diagnosis called climate anxiety. Some people now, all they need to see is a storm cloud, and they think that it's going to be a flood. And it creates a post-traumatic stress kind of issue for them, which you can completely understand if you've been through floods once or even more than one time. High temperature has significant effects on mental health aspects as well. And people have to move often, and it causes economic insecurity and involuntary displacement, which are significant issues for people's mental health. And we already have a mental health system that is somewhat taxed, and this is just an additional tax on it. And I think my final slide on climate change is really just an equity slide, because it does affect people, as I've already alluded to, who have already suffered through inequities in unique ways. I'm going to move to the next slide so I can spend some time on the latter part of the talk, but I'm happy to get into climate change more in the Q&A. I just want to emphasize again my take-home message slide on climate change, which is we need to think about it in terms of its impact on health to really bring it home. And I hope we can hammer that message home to Washington. So this latter part of the talk is going to deal with sort of how we deal with crisis in public health and what are the emerging threats. So obviously, COVID is not a current emerging threat. We haven't had a unique variant strain that wasn't in the Omicron family for several years now, but there's always the possibility that that could happen. So we just need to consider that. H5N1, public health is still very highly concerned about highly pathogenic avian influenza. And people need to just understand and realize that, we're now in fall migration for the birds, and it's still being detected in the migratory bird populations. And it can still affect barnyard flocks in Vermont. And it doesn't mean that just because we kind of escaped it this summer that we're going to do fine. It seems to come back as it will. And it's something we don't yet have a vaccine for. It's something that we have begun to see some of the earliest signs of human cases, most of them through dairy industry employees, and very benign. But it always has that potential for that DNA and molecular reassortment that would allow someone who's infected with human flu to get co-infected with an avian strain and have some genetic reassortment occur in that human petri dish. And that's what people in public health fear the most. We all know from just reading the newspaper that measles is significant in the US. We'll probably lose our status of having eradicated it this year. And we've had, we're pushing on 1,500 cases in the United States. There's still an outbreak of 100 plus on the Arizona-Utah border. We know that even in states that have wonderful immunization rates, there are going to be susceptible people. and there will be outbreaks. Vermont has had imported cases, but nothing more than that to date. Syphilis is not a disease of history, but it's still, because of the substance use disorder epidemic, still present in a vibrant way in the United States, with a subset of congenital syphilis being especially devastating. Mpox clade 1, we've done a really good job with that, but you may have just read there were 3 cases in California that California Public Health and CDC are now very concerned about in terms of what they might represent. Are they a tip of the iceberg thing? And is there going to be a recurrence of a concern on that? And dengue should be put in capital letters on this slide because it's now been seen in the southern part of our country. But again, thinking about climate change, thinking about the vectors, it may not take too much to have dengue become more endemic in our country. It is not at this point in time. It's had very significant upticks in some of the South American countries, and we just need to be very careful and watchful on that. And it's one where vaccine development is occurring, but not quite prime time in terms of safe vaccines for the population. Moving to the next threat slide. We did have a surge of COVID this summer, 6 to 8% syndromic surveillance compared to like less than 2% in quiet times. So the general population, and especially the most vulnerable, being elderly and chronic disease patients, still need to think about COVID, and there will be more COVID coming, of course, in the fall and winter. Pertussis is not a major problem in Vermont today, but it is still in pockets all around the country. And again, it has to do with increased rates of unvaccinated folk, including kids in our country. And with pertussis specifically, vaccine efficacy does wane. We have a miracle vaccine in RSV. And if you talk to any practitioner who works in an intensive care setting for kids, it's been a game changer. And even general pediatricians with hospitalizations in their kids, it's been a game changer. And thank goodness it's been around. And then just to give you a flavor for where the risks might occur, here's our vaccination rates in a state that has like leading vaccination rates in the country. So this is now data from last year, but 25% for COVID. Double that if you're over 65, but you know, during the real COVID times, we were 75 to 95% in those areas. Flu vaccine, only 36%, which was lower than the year before at 40%. RSV has an adult vaccine for those over age 70, and it's 34% of those eligible. It's a very new vaccine, so I'm going to take that as good news, not bad news. Bottom line here is K through 12 rates in Vermont, fully immunized, 94%. Think about 95% is where we always talk about community immunity. So if those numbers go down, that's not good, period. And you would wonder why we can't even be at 100% for something like polio vaccine, which most people should understand is something that's preventable, and we have a highly effective vaccine for it. Thinking about vaccination as a threat and opportunity in the current political environment, I've just mentioned community immunity, but the challenge here is, even in Vermont, if we had 95% for the population at wide, there would be certain independent schools and certain rural communities that might be 80% or 75%. So it's a little bit deceptive to look at the state rate because there will be portions of the population that will be entirely susceptible, and where we could see what happens now in Texas and Arizona, where they have those pockets where You introduce measles to those places and it flares up and a lot of people get infected. There's a continuum of vaccine hesitance, resistance, and apathy. Um, more and more people are falling into resistance because of the times we're in and almost can't be reasoned with. But there's still plenty in hesitance, which allows some clinician-patient conversation to occur in a healthy way. Vaccine apathy is also rather rampant. Um, Unfortunately, our current Secretary of HHS is doing his best to create more people who are going to be apathetic or hesitant, which is really endangering the national vaccine rates and the state of health in our country. I do think as public health, we need to communicate about vaccines better. So it's one thing to say, well, COVID vaccine didn't prevent me from getting sick. Well, that's well and fine. We shouldn't let people think we promised them that. Really, they should be happy that they only got sick, but they weren't in the hospital and they're still alive to talk about it because that's the value of the vaccine. As opposed to polio, where you can really have a severe outcome and be paralyzed for life, but we have a vaccine that can almost uniformly prevent that in anyone who gets it without much risk. Currently in the vaccine programs in Vermont, things are still happening, so good news there. But as you all know, the Committee on Immunization Practice and the federal government that advises CDC has been significantly compromised by RFK. They were all essentially terminated, new people brought aboard, many of them with vaccine anti-vax, as you might call it, philosophy, and just preserving the scientific integrity of the process is really critical to all of us in healthcare and to people who access healthcare because they want their pharmacy to have it and to be able to cover it and for there to be no confusion through mis or disinformation about the value of the vaccine. So professional organizations like pediatricians organization, internal medicine, family medicine, our infectious disease societies, all are coming together to try to provide a different voice. But that can, again, create confusion amongst the public when they're getting multiple messages. And we want to make sure the professional organizations can harmonize their recommendations very simply and all come out with the same thing without too much divergence. And then hope that we can get the clinicians and the public to listen. We've never dealt with problems like that before. Thinking about other threats, climate change apparently is no longer our most pressing urgency, and I say that tongue in cheek. But right now, there's a lot of damage being done to the infrastructure of public health, mostly through just lack of funding. A lot of funding was recently done that would modernize data structures and infrastructure and help the public health workforce after literally generations of decimating it and getting it down leveled. We were doing well. Now a lot of that money is not going to start to come our way. Haven't been a lot of people in public health in Vermont who have lost their job. However, from 2026 on is where the grants that might have been there might not be there. And that's where rescissions and work might suffer. And the entire national public health structure may suffer. If you look at Vermont, 40+% of the health department is funded through federal grants. There's another 30+% that comes through global reinvestment money through Medicare, Medicaid, and funds a lot of public health and health work. Only like 10 or 12% is state funded. And no state in this country can replace this federal money to maintain the health infrastructure they have across their state. And so the very existence of CDC is really here at risk. There are programs that you can't find now, like tobacco control and lead injury. That created a crisis when Wisconsin had a lead crisis in their water in some of the schools, and they had no one they could connect with. We've talked about public health misinformation being very important, but just having leaders like the president and RFK providing health guidance with no health credentials of their own and going really against the health guidance of most of the health establishment in the country, at worst creates, at best creates confusion, but at worst will really threaten the livelihood of many people in the country. I'm going to talk about MAHA in the next slide. That's Make America Healthy Again. It is something that should give us hope, but unfortunately, we haven't really seen how it's going to play out. So, Janet, if you can move to the next slide. Thank you. The document that they've just put out on child health is really a vacuous document. It says what it should say about food and lifestyle change, which of course is we'd all endorse, but all of the rhetoric about additives and ultra-processed foods seems to now just be rhetoric because it's not really in there in terms of what's going to be recommended for policy. And in fact, a lot of the nutrition guidance is in a time when we're curtailing SNAP payments, which is alive and well today happening for people on November 1st specifically. There are no regulations on pesticides or environmental things, which was talked about a lot. In fact, the only environmental thing that's been talked about is trying to decrease trust in fluoridation of water. And then the other things I'll just leave for now. If we could move on to the next slide. Environmental health with the status of EPA is being significantly threatened. All the work on PFAS, we're not sure where the regulations are going to go now that we as a state would like to adopt. And microplastics and endocrine disruptors are the newest things that are really significant. And I shudder to think that the work that was going on won't be funded as well anymore. Our emergency preparedness is really part of CDC. That's achieved some funding cuts, unfortunately. You compare poor preparedness with misinformation, and if something does come our way, it's going to be quite serious. Our capacity will be less. Next slide. I'm going to talk on this slide mostly about the top 3 items, but we'll start with FDA, food safety, chemicals in food, role in outbreak response, infant formula. Their workforce is lessened, so it's going to be important to see how these things continue to happen in our country. This audience of all is aware of what's going on in NIH, which the slides list, including issues of indirect costs going from 50+% in many cases to a 15% level. But really, this more rhetorical question of what are our research priorities in this country and who's going to determine them? And that's always been a process that has been collaborative and now seems a bit more autocratic to me. So happy to discuss that more in the Q&A. And then just go back one slide, please. CMS, impact on population health and healthcare reform through what's happening to Medicaid cuts and affordable care cut stipends. Very important. But let's go through WHO, USAID, and CDC to complete the talk. So this is just the definition that the World Health Organization gives of itself, just so you have an idea of the global sort of aspect of what it is. And it also leads global efforts to expand universal health coverage, respond to health emergencies. It's not just an infectious disease organization. So what are the risks that are happening, the implications? Well, it's an early warning system that we've worked with very well, because all of the things that come to our shores happen elsewhere in the world at some point in time before us quite often. And we really need that early response capability. For those involved in vaccine development, genotype data sequencing is something that's been a very collaborative process, and having access to that is critical. But if you've cut yourself off from the organization, that doesn't bode well for this. We have boots on the ground through CDC quite often to train local personnel in all of these health crises that don't reach our shores, like polio and Ebola. And then the whole issue of health security. We need data, we need early warning systems, and withdrawing from WHO is not the way to go. With regard to USAID, which is also somewhat of a done deal, this is how they define themselves, and I'll just give you a sec to read that. But the major thing USAID is all about is global health, disaster relief, helping countries that are democratic remain democratic, protecting their environments and their socioeconomic development. The implications for USAID on the next slide really are national security concerns. This whole issue of soft power, where we provided a lot of resources, not hugely expensive, by the way, that really helps us foster democratic societies and lessen their impact or the hand of autocratic and authoritarian regimes. And then, of course, the prevention and treatment of all these diseases like HIV, TB, malaria, Ebola, and of course, combating HIV through PEPFAR, the president's initiative from George Bush days. We've seen the impact immediately on our staff and our financial support and medication support being withdrawn in terms of turning into real-time deaths and transmissibility of HIV. Our final slide before we wrap up here is the risks and implications for CDC. There's been a lot of, and we don't know how this is going to pan out. There's been a lot of talk about CDC just becoming infectious disease and epidemic oriented, but I've listed a number of things that might or might not have a future, and some are rather polarizing. So injury prevention, which includes suicides, firearm safety, health equity and gender affirming care, climate change, environmental health issues, tobacco control, immunizations. Some of these might be potentially in a new MAHA administrative structure, but no one has seen what that looks like as of yet. I again think maybe there's less to worry about in chronic disease prevention, but that requires a competent leader to be able to transmit that reassurance to me. Emergency preparedness, I've talked about. You know, everyone in the country should know CDC protects US and global health security, and we know pathogens don't respect borders. We need a coordinated response. Talk to people who have just left CDC, of which there are unfortunately too many, and they are really, really concerned about this. And it's going to be hard for the private sector to just rally and provide anything that's not being provided federally. Even surveys where we monitor the health of the population, like the Youth Risk Behavior Survey, we no longer see the questions. We no longer are able to compare prior surveys and trends. This has a whole health communications and research agenda implication, which is a talk in itself. And just the whole legacy and institutional history we're losing by having people either fired or having to leave because they can't work in the environment and the effects of morale. Doesn't mean there's nothing we can do about this, but it just makes it much harder for us as professionals to sort of rally forward and get us to where we need to be. um, and try to substitute for some of the expertise that's being lost. Um, and I'll just stop there because I do want to allow 10 minutes for questions. Thank you for all your attention.
Thank you, Mark. That was comprehensive and it did make my heart drop. I have to say that. But I appreciate the honesty and the perspectives at many different levels. I see Gary has a question. Gary?
I too want to thank you, Mark, for a really valuable perspective on what's happening. To me, the principal overarching problem we're facing is an erosion of confidence in science and medicine. And I think that this is something which is very difficult to deal with. So my question, and you can get partial credit on this one, is what do you feel are the options we have to be able to constructively address the resistance and interference that we're seeing from the federal government?
Yeah. Yes. Now, this is an assault not just on public health, and I should have framed it as broadly as you just mentioned, because it does uh, come from the assault on science, unfortunately. And, the choice of evidence and almost the cherry picking of evidence that can be used. Most scientists are very willing to show their results and frame them in the context of what came before, what's occurring now, what might challenge their assumptions or their conclusions, etc. The whole discourse of science is being lost in a polarized society, unfortunately. Health communication, which is why we were so successful in the pandemic, you know, has very fundamental principles. Be first, be right, be credible, be transparent. Provide that balance of here's the strengths, here's the weaknesses, here's why I think this, but I acknowledge that people think that, and here's why I disagree with that. All of that stuff. It's to us, it's just how we live in a civilized society and how we've created our structure of health and science in this country. But because it is being challenged, we have to double up on that. Now, media unfortunately, the media most of us might read because we may be more liberal, like the Washington Post or the New York Times or the Atlantic or the New Yorker, they all publish tons of the stuff we want them to publish. And the retorts to some of the things we see in the federal government. But unfortunately, we've got to find ways to get the general public acknowledging that exists and being able to communicate with them on that. And that's really, really a significant challenge. I haven't answered your question fully because we are somewhat powerless in that regard right now. Until there's some pushback at the government levels and the division of power in our federal government, it's really a challenge.
Definitely.
It's going to take a little bit of disaster management at some time.
So is your message resist or is your message leverage that pyramid that says what can you do at the medical care level? What can you do at the protect the environment level? What can you do with changing the context?
Yeah, it's exactly what's happened in immunization, where we have healthcare practitioners still able to be one-on-one with people. We have professional organizations across healthcare coming out and saying what they believe is truth and trying to get the public to understand that. But it's a little bit of a competition. And, the people who have the most airwaves are those who are in power. And we can respect that as long as media will give equal time to others. And that's really, I think, where the issue comes about. because we're in an environment where much of the media feels a bit oppressed and unable to do what they need to do. But I think we have to maintain our professional credibility. And, I deal with that even with my professional home for state health officials, because current state health officials, and certainly their governors, want to be under the radar. And it's hard for them to express everything they want to say because they view that as threatening the money that they might get that they need to do their good work. So how do people like myself and others continue to hammer with the media in ways that will at least allow the public to get a fair glimpse at what we call truth and what we call data and evidence-based science?
People at NIH are petrified, of being able to state, the information they have and the perspectives that they have because their job is on the line. And sometimes silence is interpreted as lack of concern or opposition.
Right.
Are there others who have questions? I see in the chat, Bonita Libman has said we need to regain the trust of our patients in order to leverage news media for education about vaccines. So start with the patients that are in front of you.
Yeah, well, the good news there is when you continue to look at data and survey data specifically, the public trusts their doctor at very high rates. And they even trust their health department at very high rates. So that needs to be leveraged. We shouldn't assume that we've lost their trust. In fact, we should assume that we've gained the credibility to be able to converse with them in very direct ways. And if they disagree with us, fine. We have to respect that and allow that to happen without disowning them as a patient. But the reality is the level of trust there is actually still rather good. We've also now, unfortunately, disbanded the studies that I'm referring to that look at how to best communicate with the public about vaccines and get them to sign on to whatever vaccine you happen to be talking about. Those are now not funded anymore.
Well, in a sense, that information isn't lost, and the work that we do here and in many other places uh, is is what will bridge gaps and bring people together, I suspect. I see in the chat that there's a lot of appreciation for the work you have done in Vermont and the way that you have helped model and teach others to learn how to bridge that gap. I see Ben Littenberg has a question. Go ahead, Ben.
Hey, Mark. First
Right.
of all, I have been impressed watching you from the sidelines since you went to Montpelier. Just a hell of a beautiful job in awful circumstances. So thank you for that. The
Well,
thing
thank
I,
you.
the thing I don't understand is, um, what's the business case for wrecking science? Why are the MAGA and MAHA people uh, killing the golden goose? Do we know what their end game is? Is it just to create confusion to enable autocracy? Or is there usually there's a way they're making money off of it, but I don't see it here.
Right. That's a great question. I hope you didn't expect me to have the answer.
I figured you're the only one left who might have the answer. No one else seems to know what's going on in their heads.
Gary has the answer.
Gary?
Sometimes I wonder if it isn't just a question of theatrics and trying to go ahead and to be in the spotlight.
There's a
Well,
lot of narcissism in the White House, no doubt about it.
But even in those who run NIH now, there's a feeling that they can set the research agenda. So even if it's not spending less money, it's where is the money going? And I think that's very powerful. because there are special interest aspects of what the research would involve that can serve an agenda.
Certainly, there's a tremendous push to find a cause for autism that means it wasn't your father. I think there's tremendous pressure to relieve a father of his sense of guilt.
And now we're even funding research that has been done in the past, looking at the measles vaccine again as a cause of autism. And most of the scientific establishment is already like, that case is closed, move on. We've got bigger fish to fry. And now we're spending money again in the same place we spent it in the past. So a lot of agendas being honored, unfortunately.
I sense this is a conversation that could go on for a very long time, but I know that we have to bring this seminar to a close. So I want to say thank you again, Dr. Levine. This was a great overview and inspiring and helpful to many of us to think about how to go forward.